Welcome to Bioscan Hub. If you're ready to really master some of the most important diagnostic techniques and, explore the incredible microscopic world of the medical lab, then you are definitely in the right place. Go ahead and hit that subscribe button so you never miss one of our explainers.
All right, let's get right into it. Today, we're taking a deep dive, a guided tour of a lab procedure that is just fundamental, but it is packed with so much diagnostic power: the microscopic examination of urine sediment.
So here's our game plan. We'll kick things off by talking about why this is often called a liquid biopsy. Then we're going to jump into identifying the different cells, decoding those all-important renal casts, getting a handle on crystals, and then finally, we'll learn how to put all the pieces together to see the full clinical picture. So let's start with section 1, the liquid biopsy. And look, this isn't just some catchy phrase. It truly gets to the heart of why this analysis is so powerful. It's our non-invasive window, looking directly into the kidney.
This quote just says it all, doesn't it? We're getting a direct sample of the urinary tract's morphology. We're seeing its structure. This is information that otherwise you could only get with a needle biopsy or even surgery. It's an incredibly powerful, totally non-invasive look at the health of the entire system, all the way down to the nephron itself.
So how do we do it? Well, the preparation is actually pretty straightforward. We start with about 10 milliliters of fresh urine. Spin it down in a centrifuge to get all the solids packed at the bottom. Carefully pour off the liquid on top, that's the supernatant, and then we gently resuspend that little pellet of sediment that's left. That's it. A single drop of this stuff is all we need to start our journey under the microscope.
Okay, on to section 2, identifying the cellular elements. We're going to focus on what I call the big 3, the cell types you'll almost always be looking for: red blood cells, white blood cells, and epithelial cells.
First up, hematuria. That's just the technical term for having red blood cells, or RBCs, in the urine. And this really shows you just how sensitive this test is. A finding of even more than 1 or 2 RBCs per high-power field, if it's persistent, is considered abnormal. It's a huge red flag that needs to be investigated, because it can be a really early sign of serious kidney disease, especially problems with the glomerulus.
Next, we have puria. This is what we call it when we see an increased number of white blood cells, or WBCs. You can think of WBCs as the body's little security guards, or first responders. So when you see a whole bunch of them in the urine, your first thought should immediately be infection or inflammation happening somewhere in the genitourinary system. Now, being able to tell these two apart is absolutely key. And while there's always some overlap, here's a good rule of thumb. RBCs often point toward a problem with the kidney's filter, glomerular disease, or a bleed somewhere in the tract. WBCs, on the other hand, especially when you see them hanging out with bacteria, are a huge indicator of a bacterial infection, like a common UTI or something more serious like pyelonephritis, which is a kidney infection.
All right, our third cell type, epithelial cells, comes in 3 main flavors depending on where they came from. First, you have squamous cells. They're big, flat, look like fried eggs, and are usually just contamination from the skin. No big deal. Then you have transitional cells from the bladder lining. Seeing a few is normal, just the body sloughing off old cells. But the ones you have to pay super close attention to are the renal tubular epithelial cells. Why? Because they come directly from the kidney tubules themselves. Seeing these in the urine is a direct sign of active damage happening inside the kidney.
And hey, while you're looking for those renal tubular cells, keep your eyes peeled for these guys, oval fat bodies. Now, what are they? They are actually renal tubular cells that have soaked up fats and lipids that have leaked through a damaged glomerulus. They look highly refractile, almost like they're glowing, and finding them is a critical reportable result because they are very strongly associated with serious conditions, especially a nephrotic syndrome. Okay, everybody, take a deep breath. We are now heading into what is arguably the most important part of this whole explainer, section 3, decoding renal casts. These things are totally unique clues, literally forged deep inside the functional unit of the kidney, the nephron. So what in the world is a cast? Well, it's a cylindrical structure. It's basically a protein mold of the tiny kidney tubule where it was formed. The basic foundation is a special glycoprotein called Tam-Horsfall protein, and this protein gels up when urine flow slows down and gets acidic. And here's the vital part. Casts are the only things you'll find in urine that are 100% unique to the kidney. Their presence tells you, without a doubt, that the pathology is happening inside the kidney itself.
Before we get into the different types of casts, you have to remember this: size matters. Specifically, the width.
We actually measure a cast's width by imagining how many red blood cells could fit across it. A broad cast, one that's about 5 RBCs wide, is a very, very serious finding. It tells you it was formed in a collecting tubule that has become dilated and is likely not even working anymore. This strongly, strongly suggests severe end-stage renal disease.
Okay, let's walk through the usual suspects. Hyaline casts are the most basic, just that plain protein matrix. You might even see them after a heavy workout. But when cells get trapped inside that gelling protein, the whole story changes. Red blood cell casts, they're the hallmark of glomerulonephritis. White blood cell casts tell you an infection isn't just in the bladder, it's up in the kidney itself. That's pyelonephritis. Granular casts are just made of broken down cellular junk and point to general kidney tissue disease. And finally, waxy casts. They look dense, with sharp edges, and they tell you that urine has been sitting still for a very long time, which is associated with chronic renal failure.
So when you see those really broad casts we talked about, and they also happen to be waxy casts, a specific term should just pop right into your head. It's a sobering name for a very sobering finding, one that points to a grave prognosis. They are literally called renal failure casts.
All right, let's switch gears a bit and move on to our fourth section, understanding urine crystals. This is basically what happens when all the stuff that's normally dissolved in urine decides to, well, solidify and come out of solution.
Now, I know what you might be thinking. There are so many different types of crystals. How am I ever going to remember them all? Well, I'm going to give you the one secret key that unlocks almost everything: the urine pH. Just knowing if the urine is acidic or alkaline is your most important first step, because different crystals will only form under specific pH conditions. And this chart shows that perfectly. So in acidic urine, you might find uric acid crystals. They can be normal, but they're also linked to things like gout. You'll also find those classic envelope-shaped calcium oxalate crystals. Super common, but tons of them might mean kidney stones. Now flip over to alkaline urine, and you're more likely to see the very distinctive coffin lid shape of triple phosphate, which is a big clue for UTIs. Or you might see the thorn apple shape of ammonium biurate, which usually just means the specimen is a bit old.
And here we are, our last section. It's time for the final and most important step, connecting the microscopic dots. You see, none of these findings exist in a vacuum. A really great lab tech knows how to synthesize everything to create the complete urinalysis picture. This right here, this is your built-in quality control. Your microscopic findings must make sense with the physical and chemical parts of the urinalysis. So if you see tons of RBCs under the scope, you better believe that blood pad on the dipstick should be positive, and the urine might even look red or brown. Seeing lots of WBCs and bacteria, you should expect a positive leukocyte and nitrate test. Seeing cellular casts? Well, casts are made of protein, so that protein pad on the dipstick must be positive. It all has to fit together. So if you take away just one single thing from this entire explainer, please let it be this: always correlate. Your microscope work should confirm and explain what you're seeing in the physical and chemical exam. And if they don't match up, you have to stop and figure out why. This correlation is the absolute key to putting out an accurate and clinically useful report. Okay, pop quiz time. Let's put it all together. A patient's sediment is loaded with red blood cell casts, and the dipstick is screaming positive for protein. Based on everything we've covered, what diagnosis is jumping to the front of your mind? Something like acute glomerulonephritis should be your prime suspect. See? All the pieces fit together to tell a story. And that is our guided tour of the urine sediment. Thank you so much for watching Bioscan Hub. Make sure you're subscribed for more deep dives into the absolutely fascinating microscopic world